Welcome back to the afternoon session, and nice to see so many of you have made it through. We're going to talk about pulmonary stenosis, valvar and supravalvar now. And just to indicate the physiology here, typically there's right to left shunting through a foraminal valley because the right atrial pressure tends to be higher than left atrial pressure because of abnormal compliance of the right ventricle in patients with pulmonary outflow tract obstruction. The right ventricle, as we saw yesterday, can be hypoplastic in this. It's usually quite hypertrophied, and so the diastolic properties are not quite normal. The pressure in critical pulmonary stenosis is usually suprasystemic. It's suprasystemic in pulmonary atresia with intact septum. So again, the characteristics of this ventricle are not normal. Much of the pulmonary blood flow may be supplied through the ductus because the outflow tract may be so obstructed that very little can go antegrade. And there's desaturation of the left heart primarily due to right to left shunting here at the foramen level. So that's the basic physiology. These babies are variably blue, sometimes quite blue, sometimes very little. The pressure in here may be 3/4 to 1.5 times systemic or so, depending on how much obstruction there is. And the ductus may play more or less of a role in providing pulmonary blood flow. Here's what the valves usually look like in this kind of stenosis. Here you can see a sort of doming little valve here with commissure, with absence of commissures. There's a solid leaflet that goes all the way around. You can see there's a raphe here, here, and here in this, so that there's really no formed commissure at all in this valve. Here we see the main pulmonary artery above with the left and the right pulmonary arteries there. So the pulmonary arteries in this tend to be relatively normal size, maybe mildly hypoplastic, but usually pretty normal in size. Here's an older patient. This is a teenager with severe valvar pulmonary stenosis, and here we see the same kind of valve. You see there's a central orifice here and a solid leaflet all the way around. There's one raphe here, one there, and one up here where commissure should be but never developed in the valve. So this is a typical acommissural or doming type of pulmonary valve without the peripheral orifice. Here the fossa ovalis in this case is pretty much intact. You can see there's no atrial communication in this patient. This is an older patient. And there's the tricuspid valve here. And we'll see that there's massive ventricular hypertrophy here. Look at the right ventricle here. Look at the walls. Look at all the muscle bundles inside. There's just enormous right ventricular hypertrophy here because of the severe valvar pulmonary stenosis. And this is the outflow tract up here to the valve. You can see the valve leaflets from below. And this is the parietal band. Here's the Y of septal band. And again, you see how hypertrophied all of these characteristic muscle bundles are. Here's left ventricle and here's right ventricle, so you can see that the right ventricle is about 50% thicker than the left ventricle. Here's an example of supravalvar pulmonary stenosis. So here's the, again, the top of the leaflets of the valve are right here. So this is the sinotubular junction, and that's where we see narrowing is at the sinotubular junction. And look at how thick the pulmonary vascular wall is at this point. You see right at the sinotubular junction, it's markedly thickened. And there you can see the branch pulmonary arteries. Here's the right. You can see how thick the right pulmonary artery is. It goes straight out as a very thin tube here, and we'll look back in a second and see the orifice here in the pulmonary artery. You can see how small the right pulmonary artery here is behind the aorta. And then out into the lungs, the branches are also quite small out into the lungs. So looking at, again, into the right ventricle in this patient, you can see again marked hypertrophy. Here's the tricuspid valve, which is a little bit small, but mostly the point here is the hypertrophy of this right ventricle. We can see a little bit different pattern in branch pulmonary artery stenosis. Here you see the pulmonary trunk. Oops. There we go. Finally. Here's the pulmonary trunk coming up here. This is the proximal right and the proximal left. And you see that these are sort of tortuous. You see how the proximal parts of the coronaries of the pulmonary arteries are a bit dilated, and then they taper as we go distally. You can see also that the orifice of the right pulmonary artery here is small, and you can see that from the outside. And then there's a little bit of dilatation of the proximal part, and then it continues out further into the lung. So there's some dilatation proximally, also of the left. Here you can see this proximal left is a bit dilated, and then as we go out further into the lung, the branch pulmonary arteries become quite tiny. You can see these tiny upper lobe branches up here, as well as here to the lower lobe. So this is peripheral or branch pulmonary artery stenosis. And again, looking into the right ventricle, there's marked hypertrophy of the right ventricle, as you would expect with this kind of obstruction. This patient also has some left ventricular hypertrophy. As you can see here, there's the mitral valve. The aortic outflow looks pretty normal here, but there is some left ventricular hypertrophy. And that's basically it. Did Norm?